And we'll talk about a newer topic in context of the abstract courses, but an older topic in the subject matter. So geriatric emergency departments. How many of you have seen a patient older than 65 this year? Yes, that's why we're having this conversation. And some people think about this concept like, no, well, this is just part of what we do. We can't completely subdivide every patient population and create resources for them. That's true. But, we discovered a long time ago that pediatric patients are not just little adults, right? And we have to come to the realization that geriatric patients and certain geriatric patients are not just old adults. They do have specific needs, and if we don't focus on those needs, we cannot care for that population as well as we should. And also it results in changes in outcomes. Will they return to us? Does it impact their admission rates? We talked about ground level falls before. If we could do one thing in predicting who is at risk for a ground level fall and avoiding those, we would really improve clinical outcomes and reduce expense as well, really important. And you've probably heard this statistic before, but every day 10,000 Americans reach the age of 65. We are going to be flooded with people in this age group, no matter where you work, unless you are in a pediatric emergency department. But I have a feeling they're going to start coming there too because they're going to need it. They're going to need access somewhere. So we need to be focused on this, and part of the discussion about this is relevant to ACEP's recent introduction into accreditation. ACEP, the American College of Emergency Physicians, does not accredit emergency departments or hospitals, but they had decided and recently entered into this that there were other organizations in healthcare that felt this was a need and were going to do this and impose this on emergency departments in the United States and therefore impose it on the patients as well as on the clinicians. And ACEP thought, well, why shouldn't we be the ones to establish the standards? We have experts in our organization and in our specialty that should be doing this by emergency physicians for emergency medicine. And so I think it makes a whole lot of sense. And they're ramping up the program now. I don't know, is anyone going through the process of accreditation? Don't all raise your hands at once, please. I can't field all of these hands. No, so no one's doing it at this point. There's a good number. I don't have the exact numbers for you, but there is certainly an opportunity to increase awareness about the program. But there is a bronze level, there's a silver level, and a gold level. The gold level is like the place that does see a lot of geriatric patients, need a lot of resources. It requires a site inspection. I think it's a $10,000 fee. But on the bronze level, it's for a place that doesn't have a lot of resources but could do a few things that would benefit these patients. No site visit. It's $1,000 to get some assistance and do the right things for those patients. So I think it's right-minded, and I think it focuses the resources and the attention in the right direction. So let's move right into the first question. So what is unique about diagnostic and therapeutic decision-making in older adults? And I think this goes from Abstract 1 to Abstract 5, if I'm not mistaken. And there are some things that are distinctly different, and here are some abstracts that discuss it. Because we have 17 to cover, we're going to move through, in total for the chapter, we'll move through this pretty quickly. So the first one is really about vital signs. How are vital signs, particularly in blunt trauma, are they useful? And we know that vital signs are a trigger for trauma activation and evaluation in younger patients, and it works. These do not work in older patients, and older patients are routinely under-triaged, because mechanism doesn't seem to be as significant, because vital signs don't seem to be that abnormal. I thought this was a very interesting study that was in the Journal of Trauma in 2010. So let's talk about this a little bit. So 2,081 injured patients aged 18 to 35, and then also almost 2,200 patients 65 and older at a level 1 trauma center. Not surprising, head injury was more common in the older patients, 50% versus 31%. Mortality was, of course, greater in the older patients, 11.4% versus 2.4%. And this is one of the important take-home points. This was consistent throughout the entire range of vital signs for the older patients. So this didn't necessarily show a specific break at one point, and they go into detail about that I'll share with you. So heart rate of greater than 110 in the elderly was where it seemed to really make a bit of a difference. And then also mortality at 110 a minute was 12.6, at 120 a minute, 22.4%, and at 150 a minute, almost 70% mortality. So remember, across the whole continuum, patients still had a significant mortality rate, but there were certain breaks here where it was even worse. And it was very different than the younger population. So there was no increase in mortality in younger patients until they got to a heart rate of 150. That particular predictor, independent predictor, only kicked in at 150 beats per minute. But as I mentioned, in the elderly population, it started at 110 to make a difference. And if you look at systolic blood pressure, an increase in mortality was noted in the younger population when they dropped to 90 or below. That happened at 114 in the older patients. So we might consider that normotensive, but we don't know what their baseline is. So just be aware that vital signs are not as reliable. That can result, over-reliance on that can result in under triage. And understand that if there is a significant variation in vital sign, that is a significant piece of information that correlates pretty well with predicted mortality. So the next one, abstract number 2, a systematic review by Chris Carpenter. He has a couple of articles in here, one of our own, and he authored this chapter. So really looking at predicting geriatric falls, and I mentioned that, and that theme and that concept is pervasive through this chapter. If we could do that, it would be really, really helpful. So he did, again, a systematic review, 3 studies looking at characteristics associated with falls, 776 patients. When it comes down to it, there was very little that was very, very helpful. So let's go through some of the details. Some things were of value. So depression, someone's depressed, the likelihood ratio was 2.54. A fall, and this will not be a surprise to you, fall occurring in a previous 12 months. So if you're really good at falling, then you have a likelihood ratio of 2.27 that you will keep falling. So that's not a big surprise, but those were helpful, but some of the others weren't necessarily as helpful, and those were really the high points. What was interesting was that cognitive impairment and use of a cane, and I would think at least cognitive impairment, we've seen people who've tripped using their cane, those things were not predictors at all. They did not seem to contribute to the potential for increased falls, which was surprising. So there's some helpful information there, but how do you apply it? Does it really get us to a point where we could really predict someone is more likely to fall? I don't think it gets us all the way there. Matter of fact, there were 6 prediction instruments they looked at, and the sensitivities range from 52% to 100%, specificities from 22 to 84%, really challenging to apply these tools, and they're really variable in their application and their accuracy. So there's really nothing out there that guides us more than some of these general concepts that I mentioned. All right, number 3. So delirium in older emergency department patients, can we recognize it? There are a couple articles on this topic that I think are good to recognize because delirium and dementia are definitely different things, and if we can identify either, it's certainly going to be helpful to identify who's going to have a significant problem with outcomes later. So in general, emergency medicine misses up to 76% of delirium and over half of dementia. It's not what we're focused on, and maybe we need to focus on it a bit because it is very important in this population. So this was a convenience sample, and they used the CAM ICU tool. I don't know if you're familiar with that. It's the confusion assessment method for the intensive care unit. It can be used other places. It's even on MD Calc if you wanted to pull it up that way, but it's 6 questions. It's looking at many different things. It looks at your age. It also, looks at the time of onset. Was this acute or not? Is it fluctuating? And it scores it and lets you know if somebody's really at risk for delirium. So it's really helpful. 303 patients, 25 or 8.3% presented to the ED with delirium. And I think this is important because it speaks to our inability to identify these patients. Of the 25 patients with delirium, 76% or 19 of them were not recognized to be delirious by the emergency physician. It was a physician-based study. So small numbers, but still they missed these people. Well, maybe they weren't even looking, so we need to build this into our armamentarium. Of the 16 admitted delirious patients, 15 of them remained undiagnosed by the people who admitted them. They didn't get it either. So again, as we talked about before, if we raise certain questions, other people are likely to investigate it. And we have a very, very significant and important responsibility in that regard. So if we're worried about dementia or delirium, then we need to be raising the question for people. So basically, their take-home message was that delirium clinical decision instruments or some sort of assessment may be useful. Abstract number 4, overtreatment of presumed urinary tract infection in older women. I know that we oftentimes think this way, that, whether it's abdominal pain or some urinary symptoms or even confusion, this is an easy place to go. This abstract was unsettling to me because it really challenges, I think, what we've thought from a diagnostic accuracy standpoint. So small study, but 153 women, 70 years of age or older, diagnosed with UTI in the emergency department, and they looked at their symptoms, the method of urine collection, whether it was clean catch or whether it was cath, and they really looked at who had a culture-proven UTI. So culture was the gold standard, which makes a lot of sense. So from a urinalysis perspective, 97% were positive, either with nitrite or with leukocyte esterase. Bacteriuria or pyuria, by microscopy, of course, 80% and 86% respectively. Wasn't perfect. So culture negative in this 153 people, 43% of them were culture negative, and 58% had a clean catch, so the rest were done by cath. False positive rate, cath versus clean catch, was 31% versus 48%. So let's stop there. So even when we cath people, there were definitely false positives there. True positives, cath versus clean catch, 61% versus 52%. So we would think even if we just cathed everyone, we'd get the right answer. It's not the case. But is clean catch good enough? It's still way off the mark from catheter specimens as well. So reported urinary symptoms, this is pretty scary. So 38% with a positive culture had symptoms, and 37% that were culture negative had symptoms. What do you do with that? And this was the subset of people who could actually go through a review of systems. Remember, the patient population we're talking about may not actually be able to do that. So in the subset of people they looked at, they said either reported symptoms or did not. So there's no clear-cut answer here except for the fact that it is very clear that we are probably overdiagnosing and overtreating to a certain extent. And to that end, we need to be really very clear about how we're making the diagnosis and when we decide to treat them. All right, the next one and the final one in this section is from Stony Brook, and it's about basically ground level or low level falls over 10 years and spinal fractures. So patients 65 or older, and it had to be something less than 3 feet, the fall. This was between 2004 and 2013, and I thought there were some interesting statistics here. So they looked at 4,202 falls, 58% of those with injury in the age group. 18%, or 740, had a fracture of the spine. This is what I was surprised to read, and tell me if you feel the same way. So cervical spinal fractures, 43%. Sacrococcygeal, 36%. Thoracic, 5.7%. Lumbar spine, 4.9%, the lowest. I mean, I'm down with the cervical spinal fractures. We see them. And particularly with people who have osteoarthritis or rheumatoid arthritis, absolutely, that happens. But I was surprised that lumbar fractures, particularly compression fractures, would be so low. Is that a surprise to any of you? So this should guide us and let us know where we need to look. And it looks like absolutely look for cervical fractures in these low-level falls. And also what they identified was comparing people with and without those spinal fractures. Those with spinal fractures tended to be older, not a surprise, and more often were women, I assume because of a higher level of osteoporosis. Okay, so that's it for that section in question. The next question, do aging populations truly change the spectrum of ED presentations? Well, they would have to, and they absolutely do. So it's a bunch of abstracts here. Again, we'll move through pretty quickly. And just initially, just some concepts that are addressed in the first paragraph are worth noting. So unrecognized dementia is associated with increased ED returns, prolonged ED length of stay, increased admission rates, prolonged hospitalization, and post-ED mortality. That's why I made that comment before. I want to emphasize it now. Is this something we've really been focused on? No. We just accept that this may be their mental status and we don't look further. I think we need to be looking at this to make sure it's really what we believe it is and there isn't an underlying problem that we can treat. So abstract number 6, so frequency of dementia syndromes with a potentially treatable cause. I think this has a very curious title, and I'll emphasize why in just a moment. So the prevalence of dementia, 5 to 7% worldwide, and they're estimating a doubling every 20 years. So we're going to see a lot of patients with dementia. The authors state 5% of cases may be due to reversible causes. This is a retrospective German review, 160 patients with suspected dementia hospitalized in 2009. So these 160 patients, 62% were previously diagnosed with dementia. They already came in with that diagnosis. But 23, so about a fourth of them, had potentially reversible causes: decreased serum B12, chronic alcoholism, depression, normal pressure hydrocephalus. They had these things. And 18.2% of them ultimately did have a treatable cause. And newly diagnosed people, the different category, 31% had a potentially reversible dementia. Now, what I think is interesting about the title is, dementia, from my perspective, is very different than delirium. And when you say you have a reversible cause of dementia, I think what you just said is you're identifying delirium. And so it focuses on that distinction. It also focuses on our need to identify delirium. Not that we should really acknowledge dementia as something important, but largely, probably in most cases, dementia is probably not there's not going to have underlying treatable causes. You might be able to modify the trajectory of that disease somehow, in some way, but it's not necessarily reversible at that point. Abstract number 7, accuracy of dementia screening instruments. And there were a few that were helpful: systematic review and meta-analysis of 9 studies. The average prevalence, which is important to note, was 31%. And the reference, which limits all of these, in 8 of the 9 studies was the mini mental status exam, which is pretty easy to do, but that's the reference standard. Blinding was inadequate in 4 of the studies. The most accurate one for ruling in dementia was the AMT4 score, abbreviated mental test. So it's easy to do as well. You can look that up. The likelihood ratio was 7.69, so it's helpful. And the most accurately ruled out was done by the brief Alzheimer's screen, and I have to admit I haven't seen that. The likelihood ratio was 0.1, so really good negative predictive value there. So you could consider those if you wanted to build those into an EMR or even use it on your phone if you felt it was something you needed to incorporate into your practice. All right, abstract number 8, care and respect for elders in emergencies program. There's not a lot of data here. It's just important to note that adding resources, especially to accommodate any new geriatric needs that the patients will have, doesn't necessarily have to require physician or nursing level resources. So there is this program that was put into place at Mount Sinai, quote unquote, care and respect for elders with emergencies, the CARE program. They use volunteers. They put them through a 7-hour training process, and they were able to intervene with patients that were identified, interacted with 30% of ED patients over the age of 65, and made sure that they were kept engaged and they were kept informed, and they felt that it was beneficial and it was low cost, and they felt it was fairly high yield. So something to consider. Abstract number 9, minor injuries in older adults have different characteristics than younger adults. I think they could have been a little more creative with the title. I think we know that. But what's important about this Australian study is that they do look differently when we think it might be something that doesn't require a lot of resources. It still might. So this is in one single ED 2012, almost 3,600 patients, 10% of all ED visits, 46% of all visit injuries. And sprains and strains, not a surprise, more common in the younger patients. So fractures and dislocations, more common in the older people. Younger people are more flexible, and they're more resilient that way. So the sprains and strains, 36% younger versus 31% older. Fractures and dislocations will definitely flip that. 32% more common in the older, 20% in the younger. So it's not perfect data, but gives you a sense of what the demographics look like when you're looking at these minor injuries. And injuries due to falls, this is really important, and probably the best piece of information from this abstract. Injuries due to falls occurred more often in the elderly, 61% of the time. Can we predict who's going to fall? Depression, dementia, delirium. Can we predict delirium and dementia, especially delirium, knowing that adds to bad outcomes and predicts it as well? And then does it also contribute to falls, knowing that this is where these injuries are coming from? We talked about it in the panel as well. They can have serious injuries, although it's not the focus of this particular article. Low-level falls or ground-level falls should not be intended to or interpreted to mean that those are not important mechanisms for that age group. All right, abstract number 10, we're moving right along. So the incidence of intracranial hemorrhage, ground level falls, if you're taking any sort of anticoagulant or antiplatelet agent, but they didn't consider the novel oral anticoagulants here. And the take-home message here really is, I think, is pretty interesting. Yes, the overall rate of intracranial hemorrhage in this subset, so they had to be taking something, they had to be older, and they had to have a ground level fall, was 15%. That should tell us right away that this is a high-risk group that we need to be paying attention to, whether it's aspirin or clopidogrel, or it was something else like warfarin. So looking at the retrospective review, most of the patients were on aspirin, 44%, followed by warfarin at 38.8%, clopidogrel 16.9%. There was no statistically significant difference in these different agents, in the intracranial hemorrhage rate, the type of hemorrhage, the need for craniotomy, or mortality. It didn't seem to be a predictor. What were significant predictors were if you had a GCS of less than 15, the odds ratio for intracranial hemorrhage was 2.29. If you had a loss of consciousness, the odds ratio was 3.14. And also, if you had hypertension, which I found more surprising than the last two things, your odds ratio was 1.91. So have you changed your cerebral vasculature enough that you are somehow predisposing yourself simply because you have a history of hypertension? I think we need to file that away and realize that that is a predictor here, and that may either contribute or identify patients who may have an increased risk for intracranial hemorrhage. So basically their conclusion was the type of anticoagulant may not play a critical role in the rate, but just the fact that they are on it. And as we talked about earlier today, if you're in this advanced age group and you have some sort of head trauma, I don't think you need to qualify it. Well, that's just an abrasion, that's just a this. If it's potential head trauma, you may want to image it. And the last one in this section is number 11, and it's kind of interesting, but I don't think it really gives us a lot of good information. Basically what they said, they did the ACT alert. So the ACT alert is if you're older than 65 and you were on anticoagulants and you hit your head, we want to have a protocol that expedites your evaluation, to have coagulation studies drawn, to get the CT, do all of this stuff. Well, the operational metrics improved. They got the CT quicker. They got the results back for anticoagulants. Yes, but did it really help anything else from an outcome standpoint? Not really. And you know what was scary? I think they needed this. I'm not sure the rest of you do. Because when you look at the control group, this was a similar group of people. So we're talking about people who had a fall, who had a head injury, who were on anticoagulants. 22% of the controls never got a CT scan. This study was about figuring out how to be more efficient with this and do a better job for these patients. I think the first step is making sure the right patients get the right tests. 22% of their controls never got it. So I think in this population, we need to be imaging them for sure. All right, the next question, how accurately can ED providers identify vulnerable older adults at risk for preventable adverse outcomes like returns, functional decline, or readmissions? Those are a lot of things to be aware of. So let's run through this set of abstracts quickly also. So abstract number 12 is a systematic review and meta-analysis, also by Chris Carpenter. 7,940 citations. This man worked really hard to look at everything. They identified 34 studies. Individual risk factors were to look at outcomes and decide who is going to need further intervention, who we should be worried about. And they looked at many things. I won't go into all of them because the take-home point is none of these risk factors could really tie directly to a patient that we really should be more concerned about. They did look at, I'll mention quickly, dementia, delirium, age, dependency, malnutrition, all kinds of different things, and none of it really came to fruition. So it just speaks to the challenges when we have one of those patients in front of us. How do we decide who really is at risk? Well, we already know ground level falls. If they come in with a fall, that's probably a social service consult at this point. Didn't used to be. Well, how do you feel now? You seem like you're walking fine now. It was probably your carpet. Maybe you tripped on your dog or whatever it was. It's a fall. You're at great risk. And if we know these very, very critical pieces of information, I don't think we need to get bogged down into the details of what doesn't work. All these tiny pieces of dissected information that people have tried to tie back with associations to bad outcomes, because we have enough information to act here. Moving on to abstract number 13. Also looking at developing and validating a prediction tool for adverse outcomes in elderly patients seen in the ED. So they developed this tool. They had a derivation cohort of 751 people. Median age was 78 years. And they validated with another cohort similar, 881 patients, a little bit older. Median age was 80. The primary outcome was composite of functional decline or death at 90 days after the ED visit. 230 patients, so about a third, met that primary composite outcome, and 9.5% of them actually died. So the validation cohort had similar numbers, 28% and 9.5% of them died. So they said the final prediction model, which included age, ED arrival by ambulance, number of medications they're on, I think others in the literature said 6 or more, help needed for bathing or showering, and you don't have to ask, you'll just know. And some other issues such as hospital admission within 6 months or history of dementia. I don't think you have to know how it scores. I don't think that's important. What they were able to do was identify the factors that were considered that seemed to contribute to bad outcomes. And I think if you keep those factors in mind, you'll know who to be worried about. So they said in the highest risk group that they identified, up to 69% experienced a composite outcome, and over a third, 36%, died. So those factors are important to me. Calculating some score with somebody's clinical decision instrument, I think, is much less important than knowing what the parameters are to look for. All right, so we'll go to abstract 14, and this is a quick one. They did some focus groups to really identify where the vulnerabilities are. ED nurses, when they were surveyed and they had their focus group, they identified access to resources as the missing link. If you don't have resources for these people, clinical but also social resources, they're not going to do well. And there were multiple themes, 5 themes, but they focus around the complexity of these patients, logistical problems, cognitive challenges. There was a gap in provider knowledge about how to care for these patients, and I won't run through all of them. If you want to investigate or evaluate these in further detail, it's abstract. It's abstract number 14. All right, so 15, these are predictors of outcomes for ICU admission. And this may or may not be worthy of note-taking at the end of it, and I'll explain in a moment. I like the study, but their conclusions are like, wow, you could have just said that at the beginning. We didn't have to read the rest of it. But there are some good pearls in here, and we'll go through it. So 52 patients, a small study. They were over 80 or 80 years of age. They looked at the Apache 2 score, and these are people going into the ICU. So how could they tell all ICU comers in this age group who's sicker and who isn't? The Apache score was 24.7. The mean, that range is just so you're familiar with it, 0 to 71. The mean clinical frailty score, which has been used in orthopedics and other specialties, was 5.8. That ranges from 1 to 9, from very fit to terminally ill. 88.5% were frail. That's greater than or equal to 4. 24 patients died during the hospital stay, and that was 46%. And 13, which is 25%, died actually in the ICU. And mortality was not predicted by the Apache 2 or the frailty scores. They didn't help. So this is the part that gets interesting, that they said really predicted the outcome was when patients needed mechanical ventilation and vasopressors. That's the disappointing part of this. Really, okay, so sicker patients tend to die more in the ICU. Thank you. Thank you for that. But it is helpful to know that when we see what appears to be a critically ill elderly patient, there may not be a way to say, well, you are more stable than another. That's the important thing. We know sick when we see it, and we know when patients need resources like mechanical ventilation that they are sicker than the average. And in this age group, of course, they're going to have a higher mortality rate than those who are at a younger age group. But certainly not something that we can overly heavily rely upon that we didn't know already. All right, so the last question and the last 2 abstracts. What proof exists that any of the geriatric ED guideline recommendations improve patient outcomes or reduce costs? This is a challenge. There's not great data out there, and I think through the ACEP Geriatric Emergency Department Accreditation or JETA program, data will be collected. But I think there are some common sense principles that have been identified that make sense, and some part of the process of accreditation, particularly at the gold level, are doing multiple performance improvement projects to see what works, so we can all collectively have a better understanding of what we can do for these patients. So abstract 16 was something very simple, and basically at Northwestern, they used a vulnerability screen to target select patients to be screened by a geriatric emergency department nurse liaison. And the patients that were identified had an assessment for dementia, delirium, fall risk, and caregiver strain, which is a new metric I hadn't heard before, but makes sense. If you can't care for somebody, they probably shouldn't go home. About a third, so 29.4% of the patients were referred to the geriatric nurse in the ED, and follow-up within 3 days was achieved in over 90%. So whether you do it this way or not, I think is immaterial. But what is important is if you identify people that need the resources and you apply them, they're likely to benefit, and you can certainly make sure that there is appropriate follow-up. Now, having said that, 13% reduction in ED admission rate, so that was a positive outcomes metric, but they really didn't impact the short-term ED returns or the 30-day readmission number. Now, maybe in a larger study they would have. And finally, abstract 17, and we'll end on this, is really trying to figure out, in complex emergency departments that are overcrowded, what can we do with these patients oftentimes when we don't have a place to send them and home is no longer an alternative for them? Frailty units are being developed, so maybe that's a subset of observation units, so there are other things to look at. And this abstract, number 17, done by Wright, they talk about a triage and rapid elderly assessment team, a TREAT team. And so there would be a comprehensive geriatric assessment to make sure that they get the right access to resources and better outcomes. So the program was not associated, unfortunately, with any change in ED discharge rates, but admitted patients spent, on the average, 1 day less in the hospital. So is the data very, very strong to show that when we intervene with these patients, we can improve outcomes? It isn't, because we haven't really focused on it yet. So I think we need to give these programs time, really employ the interventions that we think are, from a common sense perspective, will benefit them, and then over time gather the data we need to prove that we've really improved the outcomes for elderly patients. So I know it's a challenging topic, and I really appreciate you listening. And while Rick is working his way up here, I'll answer your question, sir. So you were saying, I believe you're saying they implemented a program kind of like the TREAT program, where someone was assigned to go intervene with these people, and it was so difficult, and maybe it was so challenging to actually make an impact. If you do nothing but that. They came out of there looking like they were coming in. So he said, so the emotional burden of doing that was just too great to continue the program. Wow. Well, thank you for the input. And really, thanks again for your time and attention. We'll see you tomorrow.